It's okay?
Yeah, okay,
Hi.
sir. Okay, sir. Thank you, sir. Good morning, sir.
Good morning.
How are you, sir?
Yes. Sorry, I just finished my clinic. Sorry.
Okay. No, sir. Nothing. It's very. We are very thankful that you have given your precious time to this CME,
Okay.
sir.
Thank you.
Let me introduce Dr. Chow first. Dr. Tony is currently working in the Sing Kong Wu Memorial Hospital, Taiwan, under Taiwan University. He is certified board Taiwan Academy of Facial Plastic and Reconstructive Surgery. He specializes in sinonasal facial plastic and reconstructive surgery. He is widely recognized worldwide and especially in this Southeast Asia as a leading rhinoplasty surgeon. He is called upon in various workshops, conferences to demonstrate his rhinoplasty skills. He's in and he has a page also by the name of nose.tu, and Facebook and link also is there. Am I correct, sir? Tony, sir, can you hear?
Yeah, I can hear.
Okay, sir.
Thank you very much. Thank you for the introduction.
Okay, sir. Sir, the second panelist is Saharia, sir, Dr. P.S. Saharia. He is a leading senior most consultant in Max Hospital, group of hospitals in Shalimar Bagh and Patpatganj. He has a vast experience in rhinoplasty surgeries, and he's also invited in various conferences and workshops to demonstrate his techniques.
Can you throw some light onto my face? It seems to become very dark.
Sir, I'm trying, sir. One second.
I have a lot of bright light here, but I don't see it the same on the screen.
Sir, you can tilt your screen, sir. It will become bright, sir. Hello. Tony, sir, are you there?
Yeah, I'm here.
So, sir, first of all, we will start the panel discussion. Should we start, sir?
Okay.
Rahul?
Sir, can we start, sir? Sorry, sir, can we start? Sir, can you hear me? Sorry, sir.
I do hear you, but my face is very badly lit right at the moment. I don't know what has happened to the.
Sir, you tilt your screen backwards.
ये लाइट बंद करना था देखो. अरे बिल्कुल ही खत्म हो, ऑन कर दो. ओके, चलो वो जला दो.
Shall we start, sir?
Yeah, you could start.
Okay,
whatever the face looks like, that's fine.
Sir, you can tilt your screen, sir, forward.
Okay.
So, sir, number one question to Saharia, sir, to you. Open versus closed rhinoplasty, your opinion.
What is?
Sir,
Open versus.
Can you repeat the question, please?
sir, whether you will prefer open or closed rhinoplasty, your opinion?
Well, to my mind, I think the closed rhinoplasty is a better procedure when we are doing cosmesis. We'll avoid any scar outside, as well as do a quicker job compared to a open rhinoplasty. So my mind, I would like to take up only closed rhinoplasties compared to open rhinoplasties.
Okay. Dr. Tony, hello.
Okay.
Sir,
Can I show my screen?
Yes, sir. We can see you, sir.
No. Can I show my slide?
Okay, sir.
Just a second.
Can you see my slide?
No, sir, 1 second.
Okay. Maybe I just talk or.
Sir, we've made you the host. You can show your slides now.
Sir, you can show your slide now, sir. Share your slide, sir.
Okay. Oh, okay. I will show. Can you see my slide?
Not yet, sir.
Not yet.
So you'll have to share your screen, sir.
So
Share your screen, sir. Share screen.
yeah, I want to share my screen.
So there's an option share screen on the Zoom platform. If you use that, you can show us your slides as well.
Yeah, I click the screen to share. You cannot see?
No, sir, not yet.
Okay. But I have clicked the share my screen.
After sharing the screen, you click the slide, sir.
Okay, can you see now?
Yes, sir.
Okay. So I will talk about the surgical approach. I think surgical approach can be closed or open. Just as the doctor said, the closed all the incisions are intranasal, so no visible external incision. But it's limited exposure and less trauma. But the open have the columnar incision. So for me, I think the closed approach I use it for the nasal tip surgery and the subtle deformity. And for the some people have the thin skin and the strong alar cartilage. But because I do most of the cases for Asian rhinoplasty, so I think for the non-Caucasian nose, most time I will use the open approach because they have a very weak alar cartilage and need a significant projection, especially for the patient have a significant teeth deformity and secondary rhinoplasty. And sometimes I think cookie nose can be used by the open or closed approach. That's my opinion. Can you hear?
Yes, sir, we can see.
Yeah, we can hear you.
Okay.
Sir, second is how appropriate is endonasal approach in modern day rhinoplasty? Tony, sir.
Okay, okay. So for me, I think if I will discuss which approach is best for the patient during the consultation. If the patient is secondary rhinoplasty or they need to do some rib, use some rib cartilage to do the reconstruction, I will choose the open approach. But if the patient just have some minimal deformation, I will use the closed approach.
Saharia sir, your point on endonasal approach?
Can you hear me?
Yes, sir, we can hear you. We can hear you, sir.
Yeah, I do hear you.
Saharia
Yes,
sir, you...
so for me, most case, because I work in my medical center, most time the patient just referred by the clinic. So most time I do the patient for the secondary rhinoplasty. So most time I prefer use the open approach for me. And maybe but some doctor is good at the closed approach. I think every approach have their benefits. So every doctor can choose which one he like. Yeah, that's my opinion.
Saharia sir, your point?
Beg your pardon?
Sir, whether endonasal approach is appropriate in modern day rhinoplasty?
Well, for a beginner, probably a open rhinoplasty is a good procedure so that they can visualize things directly and modify them according to the requirement of the patient. But when it comes to cosmesis, I think a closed technique would be better compared to a open rhinoplasty.
Next is either alloplastic implants versus autologous implants. Saharia sir, what do you prefer?
Beg your pardon?
Sir, alloplastic implants or autologous implants?
Well, as regards the implants are concerned, I think I'll use auto-cartilage more than any synthetic material to be utilized for augmentation rhinoplasty, because I've been using marceline mesh for that matter, and out of 5 patients, 2 of them brought out the threads of the marceline mesh. One I had seen, which was operated in Korea sometimes, and she was seen and checked and found that there was a cartilage or celastic implant was protruding out into the nostril, which had to be removed. So what I feel is autologous cartilage is a better implant than a alloplastic implant in augmentation rhinoplasty. While for most of my cases for augmentation, I've used the iliac crest to augment the nasal dorsum.
Dr. Tony, your opinion?
Yeah, I have the same opinion with the professor. And can I show my screen?
Yes, sir. You can. You are the host. You can show, sir. Share your screen, sir.
But yeah, I think have a lot of material we can use. Some is synthetic material, like the silicone and maple or Gore-Tex, and some composite facial implants. They are good for the healthy and the thin skin patient. But just as the previous doctor said, they have a lot of complications. Like you can see the translution from the backline, or a lot of complications after the operation. So for me, I think I have the same opinion. I think the nature is the best. So I prefer to use the ear cartilage, costal cartilage, and the septal cartilage. And the ear cartilage and the septal cartilage, I think it's for the minor reconstruction, but for the major reconstruction, I will use the rib cartilage to harvest the rib for the patient to do a reconstruction. So they can have a very huge improvement after the operation. That's my opinion.
Saharia sir, whether will you conchal cartilage or rib cartilage, sir?
Pardon?
Whether you will use conchal cartilage or rib cartilage?
Yeah, I will use septum cartilage or conchal cartilage or rib cartilage. It depends on what kind of reconstruction I need to do. For the major reconstruction, I will use the rib cartilage.
Saharia sir?
I prefer to use a iliac crest, as I said earlier, rather than using a rib cartilage for that matter.
Whether advantage of using iliac crust over costal cartilage or rib cartilage?
Because using a rib cartilage is only ensuing some extra surgery, which endangers the pleura or things of that kind, where when you're doing augmentation rhinoplasty, probably iliac crest is safer graft for that matter. Particularly in the upper 1/3, which is bony corrector on the nose, a bony graft would be better than a cartilage graft.
Tony sir, your point?
For my opinion, and I prefer use the cartilage graft than the bony graft. And I think ear cartilage, I most time use the ear cartilage for the tip plasty because the ear cartilage is not so small and pliable. It cannot support the structure. And I use the septum cartilage to do the septal extension, or sometimes for the modify the nasal dorsum. But I use the harvest the patient's autologous rib cartilage for the patient when they have a very severe trauma or they have a lot of rhinoplasty and they want to have a major reconstruction. During that time, I will use the rib cartilage. But if the patient don't want to use their cartilage, I will use a donate rib. Buy the rib cartilage from the United States. They have some home bank for the patient to do the rhinoplasty. Yeah, that's my opinion.
The next question is, over the last 5 years, how rhinoplastic techniques and approaches have evolved? Dr. Tony, your point?
Oh, okay. Can I will show my screen.
Sure, sir. Sure.
Can you see my screen?
Yes, sir. We can see, sir.
You can see? Okay. I think the next 5 years, the new rhinoplasty revolution is the preservation rhinoplasty.
1 second,
and,
sir. Hello. Sir,
can you hear?
Sir, you maximize your screen, sir. Maximize.
Sorry, can you see my screen?
Yeah, we can see, sir. Sir,
yeah.
Zoom it.
Oh, okay. I will. It's okay?
Perfect, sir. You can start, sir.
Okay. I think it's the new rhinoplasty revolution. It's the preservation rhinoplasty. It's different with the structural rhinoplasty. It's from the Ronia Daniel. And for the preservation rhinoplasty, it's a new chapter in our history. We tried is first by the Professor Ronia Daniel in the preservation library. It cannot use for all the patients, but in certain cases, it can be replaced. You can most time I use do the rhinoplasty, we have some reduction or rebuild, but it can have some preservation and reshape. They have some three parts. First is the elevation the skin slip from the subpericountry and subaustin plane, and they try to preservation the bridge of the nose. For the sometimes the patient have some nasal hump, we use the try to reduce the nasal cartilage, the nasal bone or upper nasal cartilage. But during that time, they can do some reshape and preservation the nasal bridge and try to maintain the ala cartilage with the minimal incision. So he has three components. You can see we try to preserve the Pitanki ligament. So after operation, the nasal tip won't drop. And for the bony structure, we can use the push down or let down. There are two kinds of method we can use. And there are very big the preservation rhinoplasty meeting in the NIS. I was invited to be the speaker with the Ronia Daniel in last year. So, but this year there will be in maybe September. If you are interested in the preservation rhinoplasty, they are combined with the ESPIs in this year in NIS, and you can join us to learn the new skill. Thank you very much.
Saharia, sir, your point, sir.
Well, I have no experience in the kind that she has mentioned about, but I do appreciate that. I have only like to add one more point to my use of various grafts, and I have used about 125 homografts for the septum and the upper alar cartilage to augment the nasal dorsum, and they have worked well.
Next is what is the single most
Beg your pardon?
what is the single most challenge in case of revision rhinoplasty? And
what is the single most
challenge in a revision rhinoplasty?
Well, I think the challenge is if there has been a lot of fibrosis, one has to be very cautious in lifting up the flaps and preserving as much as you can and do very minimal amount of work in revision rhinoplasty.
Dr. Chow, Dr. Tony, your views?
And okay, I will share my screen to then you see the case. And can you see my screen?
Not yet, sir.
Not yet.
Not yet, sir.
But I don't know what happened. I cannot see the.
Share option is there. Share screen.
You cannot see my screen now?
Not yet, sir. We can see you, but not your screen, sir.
But I don't know what happened. How can I show my screen?
Share screen, sir.
Hmm. So you cannot see my screen now?
Not yet, sir.
Hmm. Okay. Hmm. So I can restart again, or because I cannot. Sorry, I don't know what's happened. I cannot. Oh, okay. I'll just talk. Yeah, I know. I found. Here. So can you see my screen now?
Now we can see, sir. Perfect.
You cannot see?
Yeah, we can see, sir. We can see your screen, sir, now.
You can see my screen now?
Yes, sir. Yes, sir.
Okay. And this is a case. She received the rhinoplasty about 20 years ago, and one used the liquid silicone. And then the first time she received the silicone rhinoplasty, and then he received the liquid silicone rhinoplasty. And after 20 years, he have the redness and swelling around the ear and the nasal dorsum off and on for more than 1 year. And he visited a lot of clinic and medical center, but still in vain. So she was referred to my medical center, and during the consultation, I arranged a standard CT. You can see a very huge silicone over here, but a very severe calcification around the silicone. It's a bamboo-like silicone. So why other doctors cannot treat the patient, because most time they think the patient got the implant related with recurrent facial cellulitis. But I found she has a very rare disease. That found a very rare disease. It's liquid silicone related delay onset edematous foreign body granuloma. So during the operation, I opened the nose, and you can see the very huge silicone and a lot of calcification around the silicone. And if you have experience to remove the silicone, most times silicone is very easy to remove, which I open in your part out. But this one is very difficult to remove it. The calcification, they have a very strong adhesion to the surrounding tissue. So I need to use scissors to remove it. So after the operation, after I use because she is too old to have her rib to reconstruct. So I use the donate rib from United States to reconstruct her nose. You can see after operation, before the operation, have a very severe redness and swelling. After all the symptoms have gone. So I published, it's a very, very rare case in the world. So I published on the #1 journal on aesthetic price field to talk about the paper about the case, and got a prize in our society. Okay, thank you. Yeah, this I think it's a very, very difficult case I've met in the past.
Okay, sir. Any other cases you want to share, sir? Tony, sir?
And okay. So how many cases? Josh, sure.
Sir, as much as you can, sir. We will be very
Okay, I'll show some. Okay, this case is in a past, most time the doctor will do the rhinoplasty, use the liquid silicone to do a liquid silicone rhinoplasty. The old lady, she has a liquid silicone rhinoplasty about 20 years ago, but now she got a very severe irregularity on the nasal dorsum. So he come to my clinic. During the operation, I remove the granulation around the nasal dorsum. I can see after I remove the granulation, her nose become complete flat. So she's too old to harvest the rib, and but he don't like to use the donate rib because he's from the state person. So I use the bilateral ear cartilage for her to do the reconstruct for her. So you can see after operation, he got a better shape. And this is the first case report in our country. So this case is from the New York. And during past 20 years, she received the 4 times rhinoplasty in New York, but still have a deviated nasal dorsum and very strange shape, the natural shell. This can try triangular shape. So he back to Taiwan, and I remove the silicone and replace with the new implant and use the ear cartilage to do the little cross-track graft for her to correct the natural shell and make the nose become straight. You can see deviated back to the straight. So, okay, this is a model in our country, and by she wants to become much more beautiful and receive the rhinoplasty in other clinics. So the first time the doctor used the Gore-Tex, but got a severe infection. So her nose become contract. So the other doctor harvest her rib to do a reconstruct for her. So she have the two times rhinoplasty. One use the Gore-Tex, the other time use the rib from her. But still you can see her nose is very strange, the natural shell and the very contracted nose. Although she has the very heavy makeup. And then he got a severe trauma and broken her nose. During here, she don't have any makeup, and so he come to my clinic. You can see her natural shell is very strange, and the nose is a very severe trauma, and the rib cartilage have broken. So I prefer to do the 3 times rhinoplasty for her. During operation, I have 1.5 rib from her. You can see before the operation, after operation, I use the 1 rib to reconstruct the structure of the nose, the other rib for the shape to elongate the nose and increase the height of the nose and make the tip from the anterior and up. So you can see after operation, have the severe makeup, the nose improve a lot. But if she don't have the makeup, can you tell she is the same person? Most of patients say they are not the same person. So we just say she have the face of rhinoplasty. Okay. I finished. Yeah.
Okay. Sir, thank you very much for your valuable time that you have given to us. Sir,
You're welcome.
What are the tips you will suggest to us, to the young budding rhinoplastic surgeons, to improve their surgical skill in rhinoplasty? Sir, what surgical tips you will be giving to the young rhinoplastic surgeons?
Sorry, I cannot hear very clear.
Sir, what are the tips you are going to give to young rhinoplastic surgeons, sir? Tips for
how to improve the skill?
Yes, sir. Yes, sir.
And yes, I have done the rhinoplasty around 30 years. Okay. Yeah, I have been in the United States and Korea, South Korea to learn. For my opinion, I think for the beginner, we need to familiar with the anatomy and know different kind of material we can use for the patient to choose the best technique or material for the patient. Different patients are suitable for different material and different approach or different technique. So I think we need to learn all the technique and all the material we can use for the patient. And during the consultation, we can discuss with the patient which one is best for them to use for them. And I think just do it. You can start from the traumatic case, because trauma case is very easy for us. It's not so difficult, so easy to correct, but because it's trauma case, so just back to the normal. For them, it's more easy to for you want to do a cosmetic for the normal patient. So I start from the trauma case, and after my technique improve, I switch to do the cosmetic rhinoplasty for the patient. And in the beginning, maybe you can use implant. It's more easy than use the ear cartilage or septal cartilage. And then maybe for the major trauma case or major reconstruction, you can use the rib for the patient. It's my opinion. So
switch off ho jayega.
Saharia sir, your opinion for young rhinoplastic. Saharia sir, your tips, sir, for young rhinoplastic surgeons, sir.
Hello.
Hello, Saharia sir, can you hear me?
Question, could you just put the question again?
To the young rhinoplastic surgeons, sir, your tips, sir, for better result outcome, sir.
Well, I think the message for the youngsters is that they should take up as many cadaveric dissections before taking up cosmetic rhinoplasty, and work in a center where you are properly guided so that you can do a good rhinoplasty work, rather than venturing into and cutting out as external rhinoplasty or internal rhinoplasty. Depends entirely on how you start your work. But I think it's important to know about the anatomy of the nose before we undertake any procedures on rhinoplasty.
Yes, I agree with the professor. I think the familiar with the anatomy, do the more and more the cadaver dissection is best for the beginner to learn the skill and to do the right plan for the patient. Yeah.
I think they should have friends in the Department of Anatomy. That is very important. That is important. At least for a few, 5 or 7 dissections would be more than enough to understand the anatomy of the nose before you start undertaking rhinoplasties. बताइए डॉक्टर साहब.
I had a few questions, sir. I needed to know your views on division of tip lobule for tip correction, sir. Do you usually do it?
Could you be louder, please?
Yes, sir. I needed to know your views on the division of tip lobule for tip correction, sir.
You want to know what?
Your views on the division of tip lobule for tip correction, sir. Can you hear me?
No, the question is not clear as yet.
Okay. Sir, I needed to know your views on the division of tip lobule for tip correction.
Could you, I'm sorry to ask you again to repeat it loudly, because your audibility is very poor. You keep the mic right in front of you and then speak.
Yeah. Can you hear me now, sir?
No, it is not audible really. Yeah, maybe now.
Okay, sir. Can you hear me now? Can you hear me?
Yeah, I can hear it better than before.
All right. So I needed to know your views on the division of tip lobule. Do you usually do it for tip correction, sir? I'll put it on chat, sir. I'll put it on chat.
No, the question is not yet clear too. Yeah, Tony, you could reply in case you can hear it well better.
Dr. Tony, can you hear me, sir?
Dr. Saharia, I am repeating her question. She wanted to know the tips for the tip. She wanted to know the tip correction. Tip correction.
Tip correction. Yes.
Yes.
What do you want to know in the tip correction? The tip correction, tip is, let us say, how is the tip formed? The tip is formed by the lower alar cartilage and the nasal septum together. If the medial crura and the lateral crura of the lower alar cartilage are in right proportion to each other, it will be providing a good tip. If they are not, the lower alar cartilage has to be reduced in size and the medial crura, both sides have to be united so that you can improve the height of the tip and sharpness of the tip. It is mainly a work onto the lower alar cartilage to improve the tip.
Dr. Tony,
Does that reply the question?
Yes, sir. Yes, sir. Very much.
Q Pradeepti. Does it reply your question?
I wanted to know whether you actually
Dr. Saxena, does that question replied or yet to be replied further?
Sir, it's replied, sir. We have got
It has been
Okay.
very well.
Dr. Tony. Hello. Tony,
Hello?
sir. Yes, sir.
Yes.
Yeah, hello?
Sir, for tip correction, what your suggestion for tip correction?
So I think tip correction is the most difficult part in the rhinoplasty. It's we need to try to do some modify for the low lateral cartilage to correct the tip, the width or the height or the length. And so sometimes we can use some cartilage graft to try to modify the tip, like the calf graft or shear graft to elongate the nose or the increase the height of the tip. And for some tip is too big, we can use some select trim or some technique to try to make the tip more better. I think it's very difficult to talk about the tip correction or tip plasty just in few minutes. Yeah.
Okay. So, Dr. Tony,
I think tip is the most important part of the whole rhinoplasty. In a cosmetic rhinoplasty, tip holds the key to the shape of the nose, and that needs to be improved. It has to be sharpened and it has to be heightened so that the tip is become a little sharper.
Dr. Tony, hello.
Hello?
Yes, sir. What are the complications?
The two medial crura need to be stitched together to make a new tip of the lower alar cartilage so that to improve the tip.
Yes. Thank you, sir. Sir, what are the various complications you encounter now to manage them?
Any question, Dr. Saxena, now on this?
Hello. Hello.
Yes.
Sir, sir, various complications you encounter and how you manage them, sir.
Beg your pardon?
So what are the complications you encounter during rhinoplasty and how you manage them, sir?
You want me to reply?
Yes, sir. Yes, sir. You can.
Okay. Say for a simple rhinoplasty, I would say their complications are very, very uncommon. But when it comes to augmentation rhinoplasty, the first complication which can be there is a protrusion of the graft, rejection of the graft, or movement of the graft from the position where you have kept. So that is one complication one can have in rhinoplasties. But apart from that, one may have at least about 5 to 10% chances for all rhinoplasties to undergo a revision rhinoplasty. Not more than 5% cases undergo revision rhinoplasty.
Okay. Tony, sir, your opinion? Tony, sir, hello.
Oh, yes, I think how to deal with the complication of rhinoplasty is a very huge topic to talk about, because I give speech about complication rhinoplasty in the international meeting. I just talk about the topic about half hours. So I think it's very difficult to talk about the topic in few minutes. But it can divide to different parts, and sometimes it's from the material. For a synthetic material, maybe have sometimes the infection or intrusion and migration. We need to deal with that after the operation. For the autologous cartilage, maybe he have some absorption or some warping after operation. We need to deal with that. And sometimes it's for the technique. If you use the wrong technique for the wrong indication, maybe sometimes the patient will get a terrible result after the operation. And for the operation, the complication, sometimes we can deal in divide to the functional complication or the cosmetic complication. For the cosmetic part, we need to deal with the patient which kind of shape they want to achieve before the operation, to try to use the right technique and right material for them to achieve what they are designed, the shape they deserve. And for the functional part, sometimes the osteotomy, sometimes they will induce some middle cell collapse, and they will induce the nasal obstruction. We need to deal with that, use some spray glove or something like that. I think it's there are a lot of different complications we need to deal with. And just as I previously I showed some case, the old lady, he suffered from the liquid silicone complication, so have some irregularity. We need to remove the liquid silicone, use some cartridge to smooth the reconstruct the structure. And for the model in our country, he has some infection after the rhinoplasty, so she got the contracting nose. So we need to try to treat the infection and remove the scar tissue and reconstruct, use maybe the septum or rib cartilage to let her get the better result. Yeah.
Okay, thank you.
Could I put a question to Dr. Tony? How often you have to do a rhinoplasty with augmentation? All cases of rhinoplasty in your situation, in your country, would require augmentation, I understand.
Okay. Yes, I have been to India. I think all of your patients most time have a very high nose, and because I think your nose is similar to the Caucasian patient, But for my patient, most time my patient have a flat nose and a very short nose. So maybe 90% or 80 to 90% of my patient need to do the augmentation.
They require a augmentation. Now, what I'm trying to imply on this is that in case that is the number of cases who require augmentation rhinoplasty, and for most of the cases, most of the time, it is convenient to use alloplastic material. The chances of getting more complications with alloplastic material is much higher compared to a autograft, like from a cartilage or like from, you can use subcutaneous fat or things of the kind which are not alloplastic for that matter. The number of cases for complications will go down. That's what I'm in my mind. I do not know. Your experience is better than mine for that matter. So in that situation, if you use more of the homographs or more of the autographs, that will be much better rather than utilizing a alloplastic material which create more complications, as I could see from your slides. That's just a suggestion, feeling, because in our situation, we don't require so much of augmentation vis-a-vis your country. So in that situation, we do not undergo so many complications of you. In fact, 1 or 2 cases from your type of country or your type of noses, I have removed those elastics from the tip, which were protruding out. But nevertheless, what I'm trying to say, if you use homografts or you use autografts rather than alloplastic grafts, maybe the number of cases undergoing complication would be reduced down. And this is my observation. That's about nothing more than that.
Yeah, I agree with you. I think the nature is the best. So for the most cases, I prefer to use the autologous cartilage or homologous cartilage.
Right.
Just some patients they don't want to use the cartilage. I will use the maybe Gore-Tex to do that. And I don't use the silicone. Yeah.
Yeah. Just to supplement it, I had an opportunity to taking homographs on about 125 or 130 cases, and I utilized them for augmentation. And they, except for a little amount of absorption of the graft, they have been doing very well.
Yes, thank you for your comment. Thank you.
Welcome. Most welcome.
To Tony sir, hello, can you hear?
Yeah, I can hear.
Sir, regarding the how many cases you require revision in your cases, sir? Revision rhinoplasty.
Sorry, I cannot catch your.
Sir, in how many cases you have to revise your case, revision rhinoplasty, sir?
You mean the percentage of a revision rhinoplasty?
Yes, sir.
In my daily practice, is that?
Yes, sir. Yes, sir.
Yeah, because I work in the territory medical center, so maybe more than half of patient is a revision rhinoplasty hospital, so refer to me. So that's why most time I use the rib cartilage or to do the rhinoplasty, because they have used the ear cartilage or septum cartilage in the previous rhinoplasty, or maybe have some very severe and infection and inflammation after they use the implant. So most time, so I use the rib to do the rhinoplasty a lot. Yeah.
So, any other question from the audience and from the participants? Sir, Tony sir, one question is that how will you manage a tip necrosis?
How
will you
sorry,
manage
I can.
Tip necrosis.
Tip necrosis.
I think Rathod sir has answered that, no?
You mean the tip necrosis?
Yes, sir.
Necrosis on the tip area.
Yes, the tip area necrosis is over the skin.
I think there are a lot of causes will induce the tip necrosis. Some is to the too huge implant, so they were near protrusion or migration to have a very severe pressure on the tip. So during that time, I will remove the implant. And for the patient, they have some infection to induce a necrosis over there. I will use some antibiotic to treat the infection. And if the necrosis is very severe, I will remove the implant and use some antibiotic to treat the infection. And wait and see after all the infection or necrosis in the stable, I do the reconstruct for the patient. Use the autologous cartilage to do the reconstruct. Or for the skin, I'll use the skin graft from the posterior ear area, or sometimes I will use the how to say that, some flap from the nasal septum to outside to cover the necrosis and the berry area induced by the necrosis. Yes.
Rathod sir, can you unmute yourself, sir? Good afternoon, sir. Good morning, sir. Sir, unmute yourself, sir. Unmute.
Hello. Yes, yes. Am I audible?
Yes, sir. We can hear you, sir.
Yes, yes. Actually, Professor has answered surgical portion of this complication. Otherwise, if we take a prevention that correct dilution of adrenaline is used while during surgery, and we should not overuse the adrenaline. And second thing is the damage to the tip is superficial in nature, because the supply comes from mucocutaneous junctions. And so most of the cases, it is less of tissue loss. And plus, I have added in my answer that those who smoke, they should avoid, because the smoke as well as the digital injury, they both cause further damage to the tip. So these both things, if we can avoid, I think this complication is well taken care of.
Thank you, sir. Sir, Tony sir, does your center provides fellowship? Our residents are asking.
Yeah. Yeah, I learned a lot from all the professors' teaching. Thank you very much, and thanks a lot for inviting me to share my experience and learn the new knowledge from all of you. Thank you.
Thank you very much, sir, for giving us your valuable time. I think I know you were in OT and you have given your time. Thank you, sir, very much, sir. Saharia sir, thank you, sir. Hello, sir. Anything, sir, you want to say, sir? Saharia sir.
Yes.
Thank you very much, sir.
Thank you. Thank you very much. Thank you for the interaction that we had. Thank you so very much. It's nice to know more things from you.
So next panel is at 11:45. We can take 15 minutes break, I think. Yes, sir. So in the sir, unmute yourself, sir.
Hello, Dr. Rathod.
Hello,
Thank you,
sir.
Dr.
Yes,
Rohit Saxena.
Yes, sir.
Thank you very much.
Thank you, sir.
And Dr. Vivek Pathak. Thank you very much.